The SeCure trial was looking at a 400 micron laser in the closure of incompetent perforating veins in patients with advanced venous disease. The real take-homes for physicians were this is one of the only trials that isolated the effect of perforator vein treatment from other types of treatment that might have been done at the same time, and showed most importantly benefit to patients in terms of quality of life, which is really what they care about more than closure rates. Additionally, it did show that closure rates were better than what we had expected them to be based on a historical precedent. The implications for the findings for this 400 micron fiber kit are that we now have FDA approval in the United States for the use of this device in perforator veins, which before this trial we did not have. Furthermore, this kit has been designed specifically for use in perforators to be low profile and easy to use. So many ask which incompetent perforator veins should be treated. And certainly all perforator veins that have incompetence do not need to be treated. We have a definition of what we call pathologic perforator veins, which are those that show incompetence greater than 500 milliseconds, are greater than 3.5 millimeters in diameter, and are in either damaged skin, so see clinical class 4B and above, or near a healed ulcer or an active ulceration. Those are really the perforator veins that we studied in our investigation, and that most clinical societies have recommendations should be treated for most benefit for the patient. In my own clinical practice, in patients that have an open ulceration and have a pathologic perforator vein adjacent to it, I will treat that perforator vein oftentimes at the same time I'm treating other sources of reflux, such as the greater small saphenous vein. In patients with C5 or C4B disease, so not quite as severe as those with an open ulcer, consideration can be made to treat the perforator veins either at the same time as a primary ablation or in a staged fashion. And really that is dependent on patient preferences and the experience of the physician, size of the perforator vein, and area of the damaged skin. The SeCure trial did have some adverse events. Fortunately, none of them caused death or disability. There were several episodes of isolated deep vein thrombosis in smaller veins. There was a thrombus extension seen from a perforator vein into a deep vein in one case, and a case of superficial thrombophlebitis. Additionally, there were a few patients who developed ulcerations despite the perforator closure later in the time of the trial, and one patient that developed a wound. Otherwise, most of the patients did very well. The next steps in our view is to make sure that doctors know the appropriateness of when a perforator vein should be treated and when it should not. So now that we have the FDA clearance for this, we don't want to just have all incompetent perforator veins treated, just the ones that deserve to be and should be. So I think education is the next step. Education both about appropriateness and then education about how to do the technique for physicians that don't know how. My key message to the physicians regarding the SeCure data set was that this trial was done in a very thoughtful manner to try to exclude any confounding variables such as treating other veins at the same time. So we really tried to isolate the perforator vein treatment to see how it would benefit the patient. The data that I think is most important for physicians to look at is not the closure data, but the patient quality of life data, as that's what matters to our patients.